If your surgeon says you need an operation, you trust them. You schedule it, you show up, you go under. That's how it works. And for most of your life, that trust is well placed. But after 65, something changes that nobody sits you down and explains. Your body stops handling surgery the way it used to, and the risks jump in ways that would shock most patients if anyone actually told them the numbers. I had a patient named Gerald, 71 years old, chronic back pain, scheduled for a major spinal fusion. His surgeon told him it was the best path forward. Nobody mentioned that, for a man his age, more than half of patients develop complications from that kind of procedure. Nobody offered him the simpler option that could have kept him off the operating table entirely. Gerald's surgery changed his life, just not in the direction he was hoping for. I'm Dr. Gray. I break down the silent health risks after 50 in the simplest way possible, using real examples and zero medical jargon, so you can protect your health without needing a medical degree. Here's what the system doesn't advertise. Patients over 65 account for nearly 40% of all surgeries done in American hospitals. A JAMA surgery study found 227 procedures where the death rate for seniors was double that of younger patients. And a Yale study found that frail elderly patients going into emergency surgery face a 1 in 4 chance of not making it out. These numbers are published. They're available to every surgeon before every operation. Most patients never hear them. Today, I'm walking you through 7 surgeries that are killing seniors at rates most families don't learn about until it's too late. And this might be the most important second opinion you ever get. Most people think of surgery the way they think of getting a car fixed. Something's broken, the mechanic opens it up, repairs the part, and you drive home. At 50, that's roughly how it goes. Your body handles the stress, heals quickly, and bounces back in weeks. At 75, you're driving a very different car. Your kidneys, the organs that flush anesthesia out of your blood, work slower, so the drugs linger in your system longer. Think of it like a drain that used to clear in seconds now, taking minutes. Your heart has less backup power to handle the stress of a long operation. And your brain, this is the part nobody warns families about, becomes incredibly fragile under general anesthesia. Roughly 1 in 3 elderly patients come out of major surgery with some level of confusion, memory loss, or personality change. Some families describe it as they went in as themselves and came back as someone else. Some of them never fully come back. A Yale study found that patients aged 90 and older were 6 times more likely to die from surgery than those between 65 and 69. Seniors with frailty had a 28% chance of dying within a year. Those with dementia, 33%. The question before any surgery after 65 should never be, can we do this? It should be, should we? Surgery 1, emergency open abdominal surgery. This is the deadliest one on the list, and the one patients have the least time to think about. A bowel obstruction, a perforated ulcer. Something tears inside you at midnight, and suddenly you're being rushed into an operating room. For a frail patient over 75, this kind of emergency carries roughly a 1 in 4 chance of death. Picture 4 people sitting in a waiting room. One of them doesn't come home. The ones who do survive often spend weeks in intensive care, hooked up to ventilators and feeding tubes, followed by months of recovery they may never finish. Here's the part that stays with me. In many of these cases, the emergency didn't have to happen. The hernia, the ulcer, the bowel issue. These problems had been sitting there for months or years. The patient or their doctor kept delaying the planned repair because they thought surgery was too risky. And by avoiding the smaller, safer operation, they guaranteed themselves the bigger, deadlier one. That's the cruelest part. The fear of surgery is often what makes surgery fatal. Surgery 2, multi-level spinal fusion in patients over 70. This is what Gerald had. Spinal fusion means permanently bolting 2 or more bones in your spine together using metal rods and screws. Imagine welding 2 links of a chain together so they stop grinding against each other. The idea is to eliminate the movement that's causing pain. For a younger patient with serious structural damage, it can work well. But for seniors with the kind of wear and tear back pain that comes with age, the picture looks very different. A study of multi-level fusion in patients over 70 found that 56%, more than half, developed medical complications. Only about 1 in 2 reached what researchers would consider a real improvement in their daily life. And for patients over 80, the major complication rate hit 35%, with death rates approaching 1 in 10. But I'm not done yet. For many of these patients, simpler options exist. Targeted injections, physical therapy programs, nerve blocks, or a smaller decompression surgery that relieves the pressure without bolting the spine together. These carry a fraction of the risk, and for age-related back pain, often deliver similar relief. Gerald didn't need a welded spine. He needed someone to show him the other doors. Surgery 3. Coronary artery bypass in frail patients over 75. Bypass surgery means taking a blood vessel from your leg or chest and rerouting it around a blocked artery in your heart. Think of it like building a detour road around a traffic jam, so blood can reach the parts of your heart that were being starved. In a healthy 60-year-old, this operation saves lives every day. But in a frail 78-year-old with diabetes, kidney trouble, and multiple heart conditions, the risks pile up fast. More than 8% don't survive, and nearly a third of elderly bypass patients develop serious complications. Stroke, extended time on a breathing machine, kidney failure, or that mental fog that doesn't clear. For many of these patients, there's a much smaller procedure called stenting. A tiny tube threaded through a small opening in your wrist or groin, guided into the blocked artery, and expanded from the inside like inflating a tiny balloon. Shorter procedure, faster recovery, and for many blockage patterns, the same long-term results. Here's the uncomfortable part. Bypass surgery pays hospitals considerably more than stenting does. I'll let you sit with that for a moment. Surgery 4. Radical prostatectomy in men over 75. When a man over 75 finds out he has low-grade, slow-growing prostate cancer, which is the majority of cases at that age, the cancer is almost certainly not what's going to kill him. His heart, his blood pressure, or simply time will get there first. And yet thousands of men over 75 still have their entire prostate surgically removed every year. The consequences are real. Loss of bladder control that can last months or become permanent, sexual function that rarely comes back, and every risk that comes with putting a 75-year-old body through major surgery and general anesthesia. The alternative is called active surveillance. Regular blood tests, periodic imaging, your urologist keeping a close eye on things. If the cancer stays slow, you watch it. If it picks up speed, you act. For most men over 75 with low-grade disease, surveillance delivers the same lifespan as surgery, without the hospital bed, without the catheter, without the recovery that steals months from a life that should be lived. Surgery 5. The Whipple procedure in frail, elderly patients. The Whipple is one of the most complex operations a surgeon can perform. It involves removing the head of the pancreas, part of the small intestine, the gallbladder, and a section of the bile duct, then stitching everything that's left back together. Imagine taking apart half the plumbing under your kitchen sink and rebuilding it while the water is still running. In a strong patient under 70, this can be the only real shot at surviving pancreatic cancer. But in a frail patient over 80, even at the best hospitals with the most experienced hands, death rates can reach 10 to 15%. Complications approach 50%. Recovery stretches into months. Many patients never get back to the life they had before. Here's what nobody mentions. For some elderly patients, the expected survival with the surgery and without it is close enough that the operation itself becomes a bigger threat to their remaining time than the cancer. That's a conversation every patient deserves to have before anyone picks up a scalpel. Surgery 6. Elective aortic aneurysm repair in high-risk seniors. An aortic aneurysm is a bulge in the wall of your aorta, the biggest blood vessel in your body, the main pipe carrying blood from your heart to everywhere else. Think of it like a weak spot in a garden hose that's starting to balloon outward. When it gets big enough, doctors worry about it bursting, which is usually fatal. So they recommend surgery to patch it before that happens. The problem is that opening someone's chest or abdomen to repair that bulge in a frail patient over 80 carries a death rate of 8 to 12%, even as a planned, non-emergency procedure. And for small or slow-growing aneurysms, the research shows something most patients never hear. The chance of the aneurysm actually bursting can be lower than the chance of dying from the surgery to fix it. That's an operation that's more dangerous than the problem it's trying to solve. A smaller procedure exists, a stent inserted through a tiny cut in the groin instead of cracking open the chest. For many elderly patients, it cuts the risk dramatically, but the bigger open surgery is still done more often than it should be. Surgery 7. Total knee replacement in patients over 85. Knee replacement is one of the most successful surgeries in modern medicine for the right patient. An active 65-year-old with bone-on-bone arthritis gets a new knee and walks out with a different life. Past 85, the story changes. Patients over 85 face sharply higher rates of blood clots, infections, heart complications, and that post-operative confusion that can settle in and never fully lift. The rehab demands months of hard physical therapy, bending and straightening a new joint every day through real pain. And many patients past 85 simply don't have the physical reserves to push through it. What you end up with is a brand new knee inside a body that's weaker than before the surgery, and a recovery that stalls halfway. For many of these patients, cortisone injections, bracing, guided physical therapy, and pain management can give them meaningful relief without the surgical gamble. The knee won't be new, but the person will still be themselves. Here's your prescription. Before you or anyone you love over 65 agrees to a major operation, ask 3 questions. First, what happens if we don't do this? Make them answer honestly. You'll live with some limitations is a completely different answer from you'll die without it. Most patients never ask, and most surgeons don't volunteer it. Second, what is the complication and death rate for this exact procedure in someone my age with my health profile? Not the average number for all patients. Your number for your body with your conditions. If they can't give you that, be concerned. Third, is there a smaller option? Stenting instead of bypass, surveillance instead of removing the prostate, physical therapy instead of fusing the spine. These alternatives exist for nearly every surgery on this list, and in many cases, they deliver the same outcome with a fraction of the danger. 1 conversation, 3 questions. That's the line between an informed decision and a regretted one. Gerald told me something 6 months after his fusion that I haven't been able to shake. He said, "Nobody ever asked me what I was willing to lose." He walked into that operating room hoping to lose his back pain. He walked out having lost his independence, his confidence, and the retirement he spent 40 years building toward. Around the same time, a woman named Dorothy, 74, facing a hip replacement, came to me with one question before agreeing: is this going to give me more good years or take them from me? Her surgeon paused for the first time in their conversation and gave her the honest numbers for a woman her age with her health. Together they chose a less invasive route. She's not pain-free, but she's mobile, she's in her garden, she's living the life she actually wants instead of recovering from a surgery that might have taken it from her. Surgery is one of the greatest things medicine has ever achieved. It saves millions of lives, and I have deep respect for the people who perform it. But a surgery that's right for a 55-year-old can devastate a 78-year-old. And that difference rarely comes down to the surgeon's hands. It comes down to a conversation that should have happened before anyone walked into an operating room. Make sure that conversation happens. Now you know. The rest is on you.